to go first?
I can go.
All right.
So I'd like to show you a radiograph to start. This is from several years ago, a man with myeloma. This was part of an osseous survey. Pretty clear, some atelectasis down here. So there are some bone abnormalities that correspond to myeloma with some lucency, some endosteal scalloping, abnormal texture here in clavicle and so forth, but nothing, nothing gross. If we go to a CT scan from 2018, we see some bone sclerosis. We see abnormal texture here in spine, but we don't see any big plasmacytomas. And then if we advance to our current imaging here, we can see that time has not been kind to this person. Now there's a huge mass here on the right pushing in on the lung. There's also something outside the lung pushing in on the other side. There's pleural abnormality here. And on cross-sectional imaging, we have huge plasmacytoma here. The interesting thing is that there's abnormality of this rib here, but we don't really see the typical lesion expanding and then bursting out of rib and causing this plasmacytoma. So it really seems to be mostly extra-osseous here. There's not really the typical progression from expansile bone lesions to bursting and then setting up with these big extra-osseous masses. And then similarly, the abnormality on the left is mostly leaving the bones alone. The bones are not normal, but I can't see a bone that gave rise to these pleural deposits here. So I think this is pleural or maybe extrapleural. It really seems to be tracking the pleural space. So another case here of huge plasmacytomas, mostly extra-osseous myeloma here. So widespread extra-osseous myeloma. He's got intraosseous too, but it doesn't have the usual plasmacytomas bursting and then giving us these big extra-osseous masses. Still hard to breathe either way. And then I'd like to show you too, we were covering call from Harborview, and it's a different world there. That's our big downtown hospital with urban kinds of things. So here's a man who was involved, it was a homeless man living in a tent, and the tent caught fire. It was said to have just basically exploded. So this man came in after this inhaling smoke in this environment. And I want to show you that his trachea is pretty normal looking at this point. But let's fast forward a little bit and look at his trachea now. It's just scarred down to this very narrow diameter lumen here. So he's got this horrible subglottic stenosis from inhaling smoke in this tent fire. And let me show you what it looks like here CT wise. It's really a neck abnormality here. So we're near the glottis and so forth, and it's very narrow through the larynx and then below with the thick wall. But by the time we get farther down into the chest, things look pretty good. Now this CT is after, this is a few weeks after his injury. There's some irregularity of the bronchus here, but nothing really gross. And it doesn't look as if there's a lot of smoke damage with air trapping and bronchial wall thickening in upper lungs here. So mostly is very proximal airways abnormality here from smoke inhalation. So he had some dilations and some stenting procedures, and I have a feeling that this might be after one of those procedures with this pneumomediastinum and extension of gas into subcutaneous tissues. So really bad subglottic stenosis, dramatic tracheal narrowing from smoke inhalation. And continuing with our neck theme, this fellow was walking along with his wife and was attacked by a dog which bit his neck. So he's got gas in soft tissues of the neck, has a tube in place at the time he came in. So not the sort of result that you'd like to have. So he had this angiographic study along, these are outside studies they did the angiogram, and it does show that there are probably some pseudoaneurysms here. So he was bleeding. You can see there's this little contrast collection here that's kind of floating. It may be connected to a vessel. There were a few of these lesions like that, and there was also some damage to some transverse processes. C5 and C6 had fractures of the left transverse process. So this was a determined canine here with a big bite here and some vascular injury and some bone injury. I think I can provide a 3D image of this. So, so this little contrast collection here is one of the sites of extravasation. There was more than one. This study was reviewed by our trauma radiologists who know a whole lot more about this stuff than I do. And then the transverse process injury, I think, is shown here. There's a little separation of that transverse process there. And so it's supposed to be 2 levels that had these irregularities, cortical disruption of transverse processes from dog bite. Okay, so you know, I'm quite happy to just go back to my ordinary stuff at the U and leave this Harbor View dramatic stuff. This is a big sympathetic discharge when I read these cases, and it's just a different world of dog bites and smoke inhalation at Harbor View. Okay, guys, thank you.
All right, thanks, David. We won't. Hope you're not too traumatized.
Yeah.
All right, Peter, do you have any cases?
Yeah, I have a few. I have 3 cases. This was a nice example. I ran into this case recently, but had multiple priors. So it's an interstitial lung disease case in a former smoker. And on the right is the image from 2011. So this was biopsied back in 2008, and this came back as a DIP. So this is a nice example of a smoker with DIP. And this case was from about 10 years ago, and just kind of interesting to compare it, how it evolved over time. This is the case from this year, from February. So you can just see the evolution, and one of the main things to notice is how DIP can evolve from more of a ground glass look without much of distortion into it can fibrose over time. So you can see the traction on this fissure here, for example, in the upper lobe, and development of traction here, traction bronchiectasis. So maybe in this on the right, presumably it was more in the phase of just pigmented macrophages filling the air spaces, and has progressed to fibrotic process over the years.
Peter, did the patient quit smoking, or did they continue to smoke?
I actually don't know. I didn't check. They definitely had a history of smoking, but they've been treating them. And it has, over the last few years, it hasn't really progressed over the last like 4 or 5 years. They've been treating them with steroids. More expanded.
I think one of the clues to this being smoking related is the mid and upper lung concentration of the scarring.
Mm-hmm. Yeah. Show this one. This was just another example case. Show the initial study. Nice example of a small, you can see this crescent around the ascending aorta here. This is this is CTA, and then crescent around the descending aorta. So this is a nice example of what a intramural hematoma looks like on a contrasted study. And it's type A because it's involving goes all the way to the root. And here's the, just a few days later, this is I know they repeated a non-contrast, so you can kind of see it on the non-contrast, exactly what you would expect with a intramural hematoma. You have the hyperdensity intramural hematoma. You can see the descending also here. And then, so this was in July, and then the patient came back. So typically we expect type A intramural hematomas surgically managed. However, this was medically managed. And here's what they look like
Left gynecomastia period.
In July, or in, September 30th. So this scan was from a few weeks ago. So completely resolved. So this was a small type A intramural hematoma, which completely resolved. And there's actually some data over the past 10 years of primarily coming from Korea, some Korean institutions, but we've been publishing that smaller type A intramural hematomas can be medically managed, and they give this threshold of around 10 millimeters hematoma thickness to be a predictor for so if it's greater than 10 millimeters.
Lymphatic calcification period.
But it's still controversial. So there have been other studies showing that it should be recommending surgical management for all type A intramural hematomas, just because unlike this one, we have seen cases where they progress to a dissection into the root. So this one turned out well. Just a nice example of how the intramural hematoma can resolve non-surgically. And this one was a nice case. So this patient has, pull the initial study here. This patient has HIV, and here's his initial CT chest. This one is from January. And so here you can see some subcarinal, so some symmetric lymphadenopathy. So bilateral hilar and subcarinal lymphadenopathy. And maybe some minimal thickening here along the bronchovascular bundles, but it's pretty symmetric. And so here is a follow-up scan from August of this year. And you can see progression of this thickening along the bronchovascular bundles, and again the symmetric lymphadenopathy, subcarinal and hilar is worsened. So it's kind of looks like almost like a sarcoid pattern, but it's very symmetric and maybe more thickening instead of nodularity. And then this is the most recent scan. So these are all patient was treated for infections and obviously did not get better. So all kinds of antibiotics, progression. So this is his most recent scan, and he got biopsied yesterday, but we're presuming this is going to end up being Kaposi sarcoma. It's a very classic look for Kaposi with the bilateral flame-shaped appearance with slow grazing neoplasm going along the bronchovascular bundles. But that's all I have, guys.
Cool, thanks. I missed that. Does he have? He has known HIV.
Yeah, known HIV. Yep.
Did he have any KS features elsewhere, like skin or bowel, that they knew of?
No.
Okay.
It's skin or bowel lesions.
So one more question. Was he started on antiretrovirals somewhere in this course?
Yeah, he's been on antiretrovirals. Yeah.
Because one of the considerations is sarcoid-like reaction as part of immune reconstitution. So
Yeah. I mean, yeah.
Yeah, I showed a case of that a few weeks ago. That's what it ended up being.
yeah,
Yeah. So we'll follow up and see. I think it's going to end up being Kaposi's, but yeah, I mean, I guess that's a possibility. It looks kind of sarcoid-like, but I mean, Kaposi's looks just like this too.
Yeah, no, I agree. I thought that's what this was going to be, but David brings up a good point.
Yeah.
Okay. Awesome. All right. Well, I have a bunch
Okay.
that I can show. Let's go through here. All right. So this, I've got two related cases first. So this is a young man. He was like 30 or something, and came in with chest pain on his, and they got a 2-view chest. I'll show the PA first. And if you look at the PA, I think initially it doesn't look terribly exciting. There's some subtle findings that I'll come back to after I show the lateral. But this is the lateral from the same time, and I think the findings are anything but subtle. So I think this is one of the best examples of ring around the artery sign. We can see gas tracking along the aorta, the airways, both pulmonary arteries, sort of all the hilar structures. So a very nice example of pneumomediastinum, but this is really one of the best examples I've seen of the ring around the artery. Going back to the PA, you can see a little bit of gas here, sort of under the aortic arch. There's probably a little bit tracking up here, and then up in the neck, there's a little gas tracking sort of medially, and then you can see a little subacute gas in the neck. So when I see gas in the neck or supraclavicular fossa, I always looking for pneumomediastinum, but I was just taken aback by how subtle the findings are in the frontal, yet they're just rip-roaring on the lateral. Same time, and then here's the contemporaneous CT, where you can see just all that gas tracking along all the structures. And this is a spontaneous pneumomediastinum from whatever he was doing at the time. A lot of times you'll see it coughing, lifting weights, other kind of straining. And they're almost always young people who come in presenting like this. But I liked it because it had really subtle PA, but really nice lateral findings. Now here's another case of the same diagnosis, but even more subtle findings. I only have a portable, but the only thing I can carve out that I'm confident is pneumomediastinum is this little tiny sliver of gas just under the aortic arch there. We don't see really any gas in the neck. Maybe that's a little too loosened along that left heart border compared to the other interfaces, but that's a little bit softer call. There may be some gas tracking down here, but I'm not confident in that, but just right there. And then if we look at the CT scan of this patient, you can see there's a lot more gas than we'd expect from the radiograph, but it's not a ton of pneumomediastinum, so I suspect we're catching a little bit of this right here on the radiograph, and you can see why we're not tangential to a lot of it, and that's probably why we're not seeing it elsewhere. And there really is nothing down low. So 2 cases of spontaneous pneumomediastinum, one with subtle radiographic findings, and one with subtle on one view, but clear as day on the lateral view. This is just kind of a cute little observation on a case. So this patient has known metastatic renal cell cancer, and has lymph node involvement, and has this really juicy right lower paratracheal lymph node metastasis. You can see it's hypervascular. But what's kind of interesting is as you scroll along it here, there's this vessel that comes out of it, and it's kind of tortuous. I think it's kind of big, and it comes all the way up here, and I think it drains probably into the junction of the brachiocephalic vein and the cava right there. And it has some side branches, but it clearly comes up from this lymph node. So I think because this is a hypervascular lymph node metastasis, probably conglomerate, because it goes up pretty high, that this is just a large draining vein. But I haven't seen one of those, or at least noticed it, but I suspect it's recruited some kind of drainage pathway because it's just so much more blood flow going through there. Has anyone ever seen that before?
No.
oh, that's very cool.
Yeah, it's just, I mean, it has no clinical significance. It's just interesting. All right. This is an interesting case. Illustrates a good finding. So this was a patient being evaluated for lung transplant. You clearly he's got some emphysema and he's got some fibrosis. This was called UIP. I think most of you would disagree. And the reason why, I look at the bases, and yes, it's very advanced, but there's a lot of central disease. I think when it was called that, someone was swayed by the basal predominance. Maybe there is what looks like some honeycombing type stuff in the bases. But one of the things that we've talked about is a really nice finding, and when it's there, is the so-called straight edge sign, which we can see on the coronal quite nicely. And this is maybe a warped straight edge, but it gets the point across. There's an abrupt transition from normal-ish lung to quite confluent fibrotic lung. It's less apparent on the right, but I still think you can see a transition zone sort of right there. This interesting, this paraseptal emphysema admixed with it. This was a young guy too, and that should have been a red flag. I think he was like 50 or something. And so I would always think about a connective tissue disease or familial fibrosis or something other than just run-of-the-mill UIP. Occasionally it'll ultimately be into UIP. He's not going to get a biopsy. He's looking into transplant, but I think in this case that straight edge sign can be very helpful. And it typically suggests connective tissue disease, but unclear.
So did any of his labs come back yet, Jeff, for that patient?
No, he was seen on the outside. He was just referred here for transplant. So he was called IPF, but I'm not convinced. And we see that a lot of times. We do a more extended panel here, and sometimes they don't declare themselves right away. But I mean, it's not going to change anything at this point. But I would just not have called this UIP. It just doesn't have that look. I like the sagittals too. I actually use them quite a bit, and you can see that similar straight edge or straight interface here. It's just an abrupt transition, and you just don't get that much with UIP. You get more of a gradient, and this is really just striking in the amount of central disease. Okay, this is just kind of a fun case because it's not what you expect. So this is a young person. I think she's in her 30s, and presents with this radiograph, and you see a nice sort of bilateral upper mediastinal mass. So you'd be thinking lymphoma probably because it is bilateral. We lose the top of the aorta, the paratracheal regions abnormal. So she got a CT scan. You can see there's all these big nodes, some big supraclavicular nodes, in addition to all these upper mediastinal nodes, quite a bit of lymphadenopathy. It's not looking like sarcoid. The subcarinal space is spared, but it would be a good look for maybe a Hodgkin lymphoma until you get down here, and then you see all of this ascites and this really thick and ugly looking stomach. There's some nodes in the belly. So this is actually all metastatic gastric carcinoma, but with just extensive upper mediastinal lymphadenopathy. So it must have taken the expressway and skipped the lower mediastinum and probably came up anteriorly and dropped in here through the internal mammaries and stuff. But this is a true Virchow's node here from the metastatic gastric tumor there. So just a nice radiograph case. And if you're doing this with residents or students, you're going to be thinking the typical mediastinal things. And when it's bilateral like this, I really push lymphoma high on the list. I've seen a couple thymomas cross midline. Germ cell tumors are usually lower and more and unilateral, and the trachea is okay, so it's probably not thyroid, but in this case, just metastatic gastric carcinoma. Okay, now we get to see kind of the, we'll do one more and then I'll have to show you the two crazy cases. So this is an interesting case. This is a patient who had a lung cancer. So let's go back in time. Is this when they presented? No, I'm trying to pre-op. Maybe it's this one. Well, anyway, they had a resection. They had a lower lobectomy for a lung cancer, and were undergoing surveillance. And so this is one of the surveillance ones. There's no, there had been no residual tumor. I think my dates are off. Let me double check. Yeah, let's go back in time. There we go. Yeah, so here's the patient early post-op. We see a little bit of an effusion down there, and not much else is going on. And then let's see. So the patient had been getting, as you know, they get follow-up after a while, and then it becomes, after a time, it becomes every 6 months and then annual. So at this point, I'm only going back, there's this little soft tissue nodule here. It was not perceived at the time. So that's at that point in time. Jump ahead, and there it is there, getting bigger slowly. And then jump ahead again, and now we've got this angry looking bone with this large soft tissue mass associated with it. So this is sort of a delayed recurrence, which is very unusual, and a slowly growing recurrence in the chest wall, causing now a bone. I think it metastasized to the chest wall and invaded the bone. Now it's caused a pathologic fracture, but it's been brewing for several years. Almost makes me wonder if it's really a met or if it's a separate primary lesion, because usually lung cancer, unless it was an indolent lung cancer to begin with, but it's one of those ones when you see, I came across the last case, so I started digging back, and the patient, a lot of times our patients will get some of their surveillance elsewhere as well, and we get the images pushed over, but not a common site of recurrence, but there it is.
Jeff, did they ever get a needle biopsy? I've seen like a few cases where they seeded it from a prior needle biopsy. They'll seed either the
Yeah, I've not seen it with a lung cancer. I've seen it with, I've definitely seen it with other tumors. A melanoma seeded the part of the chest wall.
I've seen a few where they...
It's a VATS resection, so even potentially just seeding the port site, taking it out. Right?
Yeah.
But
I've seen
if they had to do the biopsy, I don't know where it was done or when.
Yeah, interesting. I saw one here where it was growing, but it was in the actual soft tissues outside. And they had actually biopsied. They did a needle biopsy, CT guided. There.
Yeah. This is the, you can see the PET CT shows quite a bit of uptake in that area. So, yeah. So, yeah, just it's one of those things that when we're always looking for recurrence along the staple lines, but you always got to also check along the pleura, but also any surgical sites as well. So, just a very unusual. I only think I've seen that a few times, so it's not something I commonly see. Okay, so this is the craziness. So this is a 36-year-old woman who complained that she was short of breath when she slept. And she gets an outpatient chest radiograph. There's PA, there's lateral, and has this just huge mass in here. But you'll notice there's not really much in the way of displacement. There's definitely some mild displacement of the heart, but the trachea is hanging out just fine. So let me get the CT right. So they get a CT scan, and she's got this just huge mass filling the upper half of the right hemithorax. Previously healthy, you can see there's a lot of collateral flow through these veins. There's the cava here being hygroscopic veins coming in. So the superior vena cava is right here. It's patent, but it is squashed. And then the azygos vein is, we're not really seeing it. We kind of see a little bit of it here. So we kind of lost the azygos vein. But you'll notice it's very homogeneous. And if you measure it, it measures water. It's compressing her airway. So they were very hesitant to do anything requiring anesthesia because the airway was so tenuous. But we figured this was probably a lymphatic cyst or lymphocele or something, it'd be the world's largest bronchogenic cyst, and it's kind of in the wrong place. But whatever it is, we felt it was probably purely cystic. So they actually stuck a needle in this and drained it a little bit. I forget how much they got, and you can see it's much smaller now. They got out white stuff that looks like chyle. So it's some kind of lymphatic thing. So the question is now what to do with it. They want to get it out because it's just going to reaccumulate. But you can see there's the cava. It's still open. This is actually the azygos vein here being splayed over it. So it's still patent. It's just really stretched thin. So I think the best approach is going to be a hemiclamshell and to get into this space and take it out. I think it's arising from the mediastinum, but I've seen lymphangiomas before, lymphoceles. I don't know really if there's a good reason for that. Maybe it is a lymphangioma, but very big, slowly has been accumulating for some time, but she felt much better after the percutaneous drainage of this. So they're going to resect that. But I thought it was just kind of one of these crazy big things there. But it's just, you see the trachea is not pushed that much. That tells me also it's pretty soft. It's kind of finding whatever it can go to move. And then,
Jeff, were there dilated lymphatics in the lower chest and the abdomen? Could you see?
No, I mean, there's nothing.
Yep.
No cysts in the lung, no nothing. I think it's just a big lymphatic. I said it's a lymphangioma or something like that.
Yeah.
So-called old cystic hygroma. And then this is another just really big mass. So this patient had an elevated alkaline phosphatase and was referred for a bone scan with no previous imaging. I can't ever remember seeing that indication. And this, you can see here is the whole body images, and there's this large mass area of uptake in the right hemithorax. There's some degenerative stuff in the joints. You can see symmetric there. So we go to a CT next. We have, as I said, no other imaging. There's bad, you can see the bad OA. And then there's this just giant mass in the right hemithorax. But you can see it's got a calcified rim. It's got some matrix in it. And the important thing is if you look here, it's in continuity with the medullary space of this rib, is the rib 6, and the spine, the posterior elements here. It's got a pretty well, it's well encapsulated. It definitely has this matrix in it. And causing some mass effect on the chest, but not much other than that. Otherwise, there was nothing exciting going on. So I don't know what this is yet, but I think it's going to be one of two things. I mean, I think it's definitely an osteochondroma in that it has a shared medullary space and the cortex is in continuity. But given its size, I suspect there's probably some sarcomatous degeneration, but it's probably a low-grade sarcoma since it's producing matrix and still is well encapsulated. And I ran it by one of our musculoskeletal radiologists who agreed with that assessment. But so hopefully one of our thoracic surgeons will, and probably with one of the spine surgeons, will have a whack at this to get it out. But presenting with elevated alkaline phosphatase, I don't know if that's related or not. I presume it is. But I mean, I've seen osteochondromas mimicking lung nodules. I've seen multiple hereditary extra-osseous on radiographs. I don't think I've ever seen something like this before, this big. But we had two large masses in a very short period of time, so kind of interesting things. All righty, well, that is all I have. I think I showed everything else. Yep. All right, guys. Well, we'll end a little early today, unless, let me see if anybody else has joined in since I last looked. No. All right, well, thanks very much. We'll talk to you later.
Thanks, everyone.
Thank you.
Have fun in Harborview, David.
I got to gird up again.